So my career focus is on heart failure, so I've primarily focused on the heart failure related studies, and there are some really fascinating results that have come out. Technically we always want to look at a positive trial, but there's a lot of negative trials that provide you a very valuable information on how to practice medicine. So there are 2 trials that are out there for device-related telemonitoring and getting these remote data that shows that it does not impact patient outcomes. Very, very important trials, because right now there is so much focus and it is so intensive and takes so much time from nurses and physicians to look at their data. And if you're not making any changes, then that's really important negative trial. We also have a study that came out looking at the use of defibrillators in non-ischemic cardiomyopathy patients that did not show much benefit. You really need to digest those data. And then there were a couple of very interesting stem cell studies which were out also. So a lot of activities in the heart failure world. Yeah, so I mean, the general sort of guidance that I can give to anybody who's attending the Congress is that obviously if you're a researcher, then you have a particular focus and you tend to go towards those programs. If you are a clinician who's a specialist, you're an interventional cardiologist or electrophysiologist, then you will be sort of going in that direction. And then if you're a general cardiologist or a nurse or a medical student, but you're basically sort of at a different career trajectory, and at that point, you really need to figure out what your sort of weak points are and perhaps where the greatest advances for science is. Because what you want to get out of a meeting like this, that when you go home, you really know the latest and the greatest medicine that you can practice today. So perhaps more of the basic science may not be for you, but all the clinical data that can affect the patient population that you treat predominantly, those are the kind of things that I would recommend focusing on. Yeah, so we presented sort of several things, but I think the most exciting thing that we presented was that we looked at these ischemia tolerant mesenchymal stem cells, which in the basic science world have been shown to be able to secrete more paracrine factors. And because most of the benefit from stem cell therapy seems to come from these paracrine activities, we hypothesized that maybe even giving intravenous therapy is good enough, that you don't need to give intracardiac injections or intracoronary injections, which, as you may imagine from a logistic perspective, is a huge deal. Because if this therapy works in the future, we might be able to give stem cell therapy intravenously even in the outpatient setting. And even if you were to give recurrent injections, you don't have to admit the patient. So this was a very early experience, only about 23 patients, primarily looking at safety, just make sure that the liver function and lung function, all the places where these intravenous cells are going to lodge are all okay. And then we looked at some efficacy markers. And what we found was that the therapy was very safe. There were no safety concerns at all. But even one step further, there was significant improvement in 6-minute walk tests for the patients, their KCCQ quality of life scores, and there were some suggestions of improvement early on in cardiac structure and function also, although in the cumulative data, we lost that signal. So I think with the safety now proven, I think the next step basically is to take this to a larger patient population and look at clinical outcomes per se, whether it can affect mortality and hospitalization rates. Huge, I mean major. So, if you look at these 2 or 3 major cardiovascular congresses around the world, ESC is the largest. So all the new science that has come out, clinical trials and other science that we can apply to the care of the patients today with any cardiovascular disease, whether it's prevention, lipid, blood pressure, diabetes, all the way up to myocardial infarction, heart failure, transplant, mechanical heart. I mean, you name it, there is nothing within cardiovascular medicine which is not covered in this meeting. So at the end of the meeting, if you have spent your time well, your patients are going to benefit from it. I think it's crucially important. It's important for many reasons. So one is that they understand science, they understand sort of the latest in medicine, but I think it goes sort of beyond that. I think many medical students may go out really motivated for maybe a different career than they thought. So maybe they'll get more motivated with research. They maybe will choose something that really attracts them in terms of the career focus. But also you will meet a lot of people who are doing really cutting edge research. So networking opportunities and also mentorship, potential future mentorship opportunities future training opportunities of where you go and get your advanced training, all of those things. So I think it will be very beneficial for medical students to attend something like this. Boy, that's an impossible question to answer. It is so huge and so big that I think you'll just have to dissect it, and I'm sure at the end of the Congress they will sort of come up with, this is the myocardial infarction, this is heart failure, this is ischemic heart disease, this is lipid. There is just way too much science going on here for me to be able to distill that. Yes, so I think the biggest thing is that if you think about other cardiovascular diseases like stroke or myocardial infarction, we think about prevention, but when we talk about heart failure, for the longest time, we just talk about treatment of heart failure. Nobody thinks about prevention of heart failure. So I think the biggest thing, at least in my career, that has happened is that in the past, about say 8-10 years, really not that far back, people are now beginning to talk about heart failure prevention. They're talking about heart failure prevention in specific population like cancer patients, like patients with diabetes, or general population at large. There are clinical trials with biomarker-guided prevention strategies that have come out to be positive, and now there's a very exciting trial that just came out with a diabetes drug that has been shown to reduce the risk of development of heart failure very substantially, over 30%. So I would say that although we haven't really solved the problem for coronary disease, we have been at it for about 50 years. For heart failure, we have been at it for about 5, 7, 8 years. But at least things are moving in that direction, and that's very exhilarating. I mean, I think there are several things. So I think what is circulating in our blood and the biomarkers, especially in this omics era that we live in, we will be able to really get into personalized medicine. So rather than giving the same therapy at the same dose for everybody, we'll be able to really target it. So I think that in my lifetime will become very much a reality. I think technological advances in machines are going to get better and better. So better defibrillators, better mechanical heart support, those things are going to come forward as well. Better systems of management will be enabled by technology. So the way we practice medicine today, maybe by the time I retire, there is no such thing as clinic. We do everything on internet and WebEx, I don't know. But I think the biggest thing is that we need to also start realizing that prevention is very important. Right now we equate health as absence of disease, but that is not health. Health is absence of risk factors. And I think this primordial prevention will get more and more sort of focus, and I think we'll be able to do wonders. Well, so the good news to your question is that there's already talks about guidelines being merged. So I think it's a long process. We're not there yet. But the fact that we have started talking about harmonizing the guidelines between US and Europe is a really essential first step. I think the differences are not really in the heart failure care and how the doctors think about it, because heart failure is heart failure and patient is patient. I think the bigger differences are in the socioeconomic status that may be different in different countries, or the health regulatory agencies and the payers and the insurance companies, and what is paid for and what is not paid for, and what do they require. So I think those are more determinants of the variability, the regional variability in care, as opposed to the doctors believing in one way versus another. But I think certainly having one set of guidelines will help as a first step to bridge some of these differences.